Hello, my name is Don Seltzer, and I am the chair of the SAGES Legislative Review Committee. I would like to discuss a process that remains relatively unfamiliar to most practicing physicians and surgeons. That is the process of creating and obtaining a CPT code and the eventual development of RVU valuation for that code. We should begin with some history. The current procedural terminology, or CPT code system, was initially developed and published in the 1960s. It was initially a 4-digit system that covered primarily surgical codes. However, it was quickly identified that the number of surgical procedures that were being performed would necessitate an expansion to a 5-digit system. The current system, the 4th edition, was developed in the mid to late 1970s and has been updated relatively regularly since. It was initially adopted by HCFA or CMS in the early 1980s, at the time that the DRG system was being developed and accepted as well. The state Medicaid system accepted these form of documentation in the mid-1980s. The development and maintenance of the current procedural terminology, or CPT code system, is labor-intensive. The CPT code system is owned solely by the American Medical Association. For its investment in time and labor, the AMA is reimbursed handedly. The 2015 code book retails for $115, and in 2014, the American Medical Association reported that its Books and Products division netted a profit of $64 million. The CPT code book and its byproducts were a large component of this net profit. The body that is responsible for the development and maintenance of the CPT code system is the CPT Editorial Panel. This AMA committee consists of 17 members, of which 11 are doctors. One member must be a specialist in performance measurement. Blue Cross Blue Shield, the American Health Insurance Plans, the American Hospital Association, and the Centers for Medicare and Medicaid are allowed to nominate one member each. 2 members are nominated from the AMA Committee Healthcare Professions Advisory Committee. This committee represents other members of the healthcare community, including occupational therapists, physical therapists, podiatrists, psychologists, and others. The committee meets 3 times a year, and at each meeting, discussion regarding CPT codes and their development and maintenance commences. Members of the advisor committee are present to discuss the CPT codes. The advisory committee consists of 300 specialties, all of which have a position in the House of Delegates within the American Medical Association. There are 3 categories within the CPT code system. Most physicians are familiar with Category 1. Category 1 represents the mainstream procedures and services that are performed by physicians throughout the United States. For example, 49505 is a code that is used to document an open inguinal hernia repair in an individual of 5 years of age or older. This code lies right in the middle of Category 1. Category 2 is not commonly used by physicians, but instead is used by healthcare entities or organizations to document performance measurement. Category 3, or the emerging technology category, is used to represent procedures or services that are relatively new, and research remains to confirm if they will become mainstream. An example of a recent Category 3 code is the Transanal Endoscopic Microsurgery Code. These codes gathered data and were eventually converted to a Category 1 code. Alternatively, if the procedure is no longer performed, the Category 3 code may be eliminated. In some circumstances, the Category 3 code may be extended if additional research is still being obtained. A Category 1 application may be submitted by anyone, including a surgical organization, a company, or an individual surgeon. The basic requirements for the Category 1 request include the device, procedure, or service must have FDA approval. The procedure must be performed by a significant number of physicians, especially consistent with how often the procedure is performed within the United States. If the aim is to treat a common disease, then the device or procedure must be performed often. For example, cholecystectomy is performed over 750,000 times each year. Therefore, a new cholecystectomy procedure would require data on thousands of patients, if not tens of thousands of patients, before it would be considered a commonly performed procedure that would be commensurate with the disease prevalence and therefore necessitate or deserve a Category 1 code. The procedure must also be consistent with the current medical practice, and finally, it must be supported by medical and/or surgical literature. The requirements for this component of the application process has recently changed and has become more complex. There are now 3 different requirements for supporting literature based upon the classification of the device or procedure. New technology would be defined as any device or procedure that necessitated an FDA pre-market approval or investigational device exemption, a panel track submission, or a de novo 510(k) application. Existing or non-contributory technology is defined as any procedure or service that has already obtained a Category 1 classification and is being refined, or a service or procedure that has completed the traditional track of the 510(k) process, or it doesn't even involve technology. An example of the final would be the new Coordination of Care Management Codes. The final classification is considered specialized or humanitarian and has been given such a designation by the FDA or has proof that the service or procedure is primarily offered to an underserved population, and ultimately research on this procedure or service would be impossible. Applicants are then asked to mark an X in the column of this table that best represents their application. The application must then provide the literature requirements defined in that column. For example, the previously provided new cholecystectomy procedure would fall under existing and would necessitate 5 peer-reviewed publications, of which 3 must have U.S. populations, with 2 having essentially no overlap of those patient populations. And the minimum level of evidence that would be sufficient to fulfill the requirements would be level 3A or 3B, in other words, a case control study or systematic review of case control studies. On the other hand, a new device would require a minimum of level 2A evidence, which includes a systematic review of cohort studies. The specialized or humanitarian category clearly requires slightly less literature support, especially for existing codes, where a case series is all that is necessary to justify the code application. Additional concepts must be considered during the application process. One must consider the impact of the new code on the surrounding families. For example, evaluation and management codes are grouped together. Radiologic codes are grouped by technology. Pathology codes are also grouped by technology. Endoscopic and surgical codes are grouped by organ system. Each code must have a short and long descriptor. However, short and long does not represent the exact length of descriptor. For example, the long descriptor for laparoscopic cholecystectomy is much shorter than the long descriptor for upper endoscopy. More important in length is the appropriate selection of words for an easy understanding so individuals will be able to use it appropriately at a later date. The application process for a Category 3 code is less rigorous. It must be currently or recently performed in humans. It must at least have one of the following criteria: an application that is supported by at least one CPT or HICPAC advisor, or an actual potential clinical efficacy of the procedure or its service documented within at least one peer-reviewed article available in the English language. It must have all of the following, however, and that includes at least one IRB protocol studying the procedure or service, a description of that is currently ongoing in a U.S. trial, and there must be evidence of its overall evolving clinical utilization. Once an application is completed, it is submitted to the editorial panel. It will then be presented at an editorial panel meeting. During that meeting, the application will be discussed, and testimony is commonly heard by the panel in either support or in opposition for the application process. Upon completion of the meeting, the panel will make a decision. That decision may include the addition of a new Category 1 or Category 3 code. It may include the revision of an existing code, for example, the conversion of a Category 3 code to a Category 1 code. It may include the referral of the code or application to a workgroup for further study. In addition, it may postpone further discussion until another meeting, or, in fact, it may simply reject the item. If the panel elects to confer at Category 1 code status upon the application, it is then referred to the RBRVS Update Committee, where it is evaluated for a recommended reimbursement. Resource-Based Relative Value Scale, or RBRVS system, was developed by a Harvard University professor named William Shao. He and a multidisciplinary team developed this system in the early 1980s. It was submitted to HCFA in the late 1980s and eventually was adopted and accepted in 1989. Its utilization for Medicare reimbursement began in the early 1990s, and it has been utilized ever since. The RVU system, or Relative Value Unit System, is a commonly used term that is easily recognized by most physicians. The RBRVS Update Committee, or as it is commonly referred to, the RUC, is coordinated and convened by the American Medical Association 3 times a year. It is tasked with the development and determination of RVU values for each CPT code. It functions as an expert panel resource for the Centers for Medicare and Medicaid Services, and representatives from CMS are invited to each meeting. The RUC represents the AMA's First Amendment right to petition the government with regard to the RVU valuations for CPT codes. The RUC consists of 31 members. There is a chair and an AMA-appointed individual. There is also an individual appointed by the CPT Editorial Panel, and the Healthcare Professionals Advisory Committee appoints a person. The American Osteopathic Association is able to appoint a member, and there are 23 other specialties that have an assigned seat. 2 seats represent rotating positions that are voted upon every 2 years. One is specifically assigned to medical subspecialties. Finally, there is a representative from the subcommittee entitled Practice Expense. This subcommittee is tasked with the specific responsibility of generating RVU values to reimburse physician practices for CPT codes that are performed in a physician's office. In addition to the RUC members and the AMA staff, the advisory committee is also able to attend each of the meetings. Once again, the advisory committee consists of over 300 specialty societies, all of which have a House of Delegates position within the AMA. The process of confirming and generating RVU valuations is a complex one. It frequently leads to contradictory events or interactions that will require a thorough evaluation to determine the most appropriate end result. However, ultimately, a CPT code is provided by the CPT Editorial Panel, and it is referred to the RUC. At that point, a level of interest is generated, and specialty societies are able to determine if there is an interest to evaluate this particular CPT code. In addition, the Centers for Medicare and Medicaid Services may request that further evaluation of ongoing codes occurs. For example, a new technology that has only been in position for 3 years will require a relatively regular evaluation early on. In addition, there may be codes that are identified as having a significant uptick in utilization or may occur routinely regularity with regard to the CMS claims database. In addition, there is frequently concern about high perioperative or peri-procedure services, for example, significant number of postoperative days within the hospital, or a prolonged intraoperative or intra-procedure services time. On occasion, codes within a family will receive an initial evaluation that appears to be inconsistent with other codes. For example, if a simple inguinal hernia repair receives more RVUs than a recurrent inguinal hernia repair, then that would be potentially problematic, as one would expect the recurrent inguinal hernia repair to be more complex and therefore require or generate a greater RVU value. Finally, there are specific systems that are available to allow for complex or evaluation process that compares codes from one specialty to a number and from one family to another. For example, the MPC, or multi-specialty points of a comparison list, allow for a list of codes to be generated that are performed by multi-specialties. For example, upper endoscopy is performed by both gastroenterologists, surgeons, and even in some circumstances, primary care physicians. Finally, there was initially a 5-year review process. This ended in 2012, as now there is an ongoing review process every year, during which time potential codes that have higher than appropriate values are reevaluated. There is an annual cycle that occurs with regard to the generation of CPT codes and then the RVU valuation by the RUC. Each committee meets 3 times per year. The RUC cycle begins in April and ends in the end of January, with an intervening meeting that occurs frequently in the early portions of October. The recommendations that are generated at these 3 meetings, including the April, October, and January meetings, are then collated and submitted by the AMA to the CMS director. In general, the RVU valuation for a specific CPT code and the description of the work associated with that specific CPT code are aimed at the treatment of the typical patient. Naturally, patients do not all fall within one specific scenario. However, there are modifiers or, on occasion, other CPT codes that describe the care of more complex or less complex patients. One must consider this when identifying the appropriate level of care for that particular individual. In addition, CPT codes include more than just the particular activity or procedure. For example, the RVU valuation for all CPT codes will include a preoperative visit that occurs within 24 hours of the initiation of that procedure. In addition, all components of care that occur on the same day of the procedure are also included for all CPT codes. For 0-day global codes, that is when the overall RVU valuation ends. However, for more complex surgical procedures, which may fall within the 10 or 90-day global period, in addition to the events prior to and the day of the procedure, all follow-up care for either 10 or 90 days respectively is also included. It is advised that an individual should avoid unbundling. In other words, there are multiple events that occur for the routine care of a surgical patient. For example, it is accepted that a laparotomy is portion of any one of the major open surgical procedures, and therefore billing for that CPT code for a standard laparotomy is considered part of all major open surgical procedures and should not be coded separately. A relatively straightforward formula is used to calculate the total RVUs for a CPT code. Total RVUs consist of a relatively straightforward formula consisting of the work RVUs, or time and activity specifically performed by the physician. This represents approximately 51% of the value of the total RVUs. 45% of the total RVUs are generally represented by practice expense. Practice expense is used to reimburse the physician's practice to offset the overhead associated with having a practice, including labor, as well as goods, including gauze, tongue depressors, and the like. Finally, 4% is used to offset the cost of medical liability insurance. The calculation of work RVUs for physician time is a formula that consists of time multiplied by intensity. In this circumstance, time components consist of not only the procedure itself, which would be identified as intratime, the amount of time taken from the skin incision to the skin closure, but also consists of pre-time, all of the activities leading up to the incision, including a preoperative visit, the standing around time involved during the administration of anesthesia, the positioning of the patient, and the prepping of the patient's skin. Postoperative care will include the amount of time necessary to fill out orders, document the overall procedure with an immediate postoperative note and dictation, as well as communicate with the family. In addition, most procedures include a postoperative check later that day. For those procedures that have an extended global period, all of the visits in the hospital and in the outpatient clinic are also included. IWPUT, or intra-service work per unit time, is used more as a corollary to help confirm that indeed the appropriate RVUs have been generated. In general, this is meant to help reflect the amount of psychological stress, the amount of mental effort, and the overall technical skill that may be necessary to perform a specific act. However, time is the major component of all calculations, and in general is stressed when it comes to physician work time. Determining the RVU valuation for a specific CPT code can become quite complex. In general, physician work and the work RVUs, or WRVUs, are generated by random surveys that are sent to members of a specialty society. In the surveys, experts will provide an estimated amount of time that is necessary to perform all of the preoperative, intraoperative, and postoperative components of care. When this data is collated and statistically analyzed, usually the 25th percentile or median values are used to identify the overall amount of time that is necessary to complete the CPT code procedure. An additional method that is acceptable to help identify the overall WRVUs includes a technique called magnitude estimation. In this regard, it is overall evaluated the amount of work and compared relatively to other members of the code family and or other members of other procedures that have similar components of time. Unacceptable methods include breaking down the code and its subsidiaries to identify different values and then building all of these values together. This building block methodology has been disregarded as an acceptable option by CMS. Finally, compelling evidence is frequently necessary when one considers if the WRVUs are inappropriate and must be increased. Because in general, it is felt that budget must remain neutral, and if one RVU is going to go up for a CPT code, it must be offset by the reduction in RVUs by other CPT codes. By identifying compelling evidence, an individual is arguing that the overall work has increased not only in this particular scenario, but for everyone as a result of this new technology or new procedure. IWPUT is usually not specifically identified, but in fact retroactively a retrograde calculation. Practice expense is a very arduous and painstaking process, whereby presenters provide information to the Practice Expense Committee, suggesting the amount of work that's necessary by the support staff and the amount of supplies necessary in a physician's practice to carry out the care of those patients undergoing those services or procedures. At times, this can become so arduous that the amount of graham crackers that are necessary to comfort a patient in the recovery suite are argued. The amount of reimbursement that is used to offset the expenses for professional liability insurance, or PLI, is determined by CMS every 5 years, although there is discussion to reduce the interval down to 2 years. Once an RVU evaluation is generated for a specific CPT code, the RUC collates all of this data and then submits it to CMS. CMS may then accept the RUC's recommendation or disregard it. In the past, greater than 90% of the RUC recommendations were utilized by CMS. However, in recent years, as overall efforts are made to reduce the overall expenditures by CMS, the RUC acceptance recommendations has reduced to approximately 79%. By July, a proposed rule is published by CMS. There is then an approximate 6-week interval during which time an open comment period is available. Then in October, the final rule is published. By December, the conversion factor is identified with the final rule. This is then instituted on January 1st of the following year. It is quite complex to eventually receive the number for reimbursement. Therefore, it is helpful to go through an example on how different locations receive different reimbursements for the same CPT code. In my home state of Indiana, a laparoscopic cholecystectomy will be different reimbursement than it is in other locations. Let's see. The work RVUs that are proposed for a laparoscopic cholecystectomy are 10.47. The recent Affordable Care Act has set some floors for the geographic practice cost indices. Specifically with regard to work RVUs, the Geographic Practice Cost Index, or GPCI, has a floor of 1.0. Therefore, multiplied through, the work RVUs that are provided for reimbursement of laparoscopic cholecystectomy in Indiana are 10.47. However, when one considers practice expense, the proposed value of 6.09 is multiplied by a GPCI of 0.921, rendering a value of 5.61 in Indiana. Finally, the reimbursement for practice professional liability insurance is 2.44 as the proposed value, but when multiplied through in Indiana at a rate of 0.617, this provides an RVU value of 1.51. Therefore, the initial proposed value for total RVUs for laparoscopic cholecystectomy are 19. But in reality, if one is performing this procedure in Indiana, what one receives is 17.59 total RVUs. Multiply this total RVU by the conversion factor for 2015, and one can see that the actual reimbursement for a cholecystectomy for a Medicare beneficiary to a physician and his practice is $611.05 in the state of Indiana. Naturally, one could expect that there might be different costs for performing a procedure in different environments. Let's look at Alaska. A laparoscopic cholecystectomy in Alaska also has a total proposed value of 19.00 RVUs. But as one can see, the work RVUs here are multiplied through by a GPCI of 1.5, rendering an actual reimbursement of 15.71 RVUs for physician work. Practice expense is also greater than 1, and renders a value of 6.74 RVUs. Finally, professional liability insurance is multiplied through by 0.712 for a value of 1.74 RVUs. Therefore, an individual who performs a laparoscopic cholecystectomy in Alaska will actually receive a greater than proposed value of total RVUs of 24.19, multiplied through by the conversion factor reveals a total reimbursement of $864.91, a difference of greater than $250 to my home state of Indiana. When one evaluates the coasts, one sees a completely different picture. Here in San Francisco, it is recognized that it is very expensive to rent and maintain a practice. Therefore, when one looks at the geographic practice cost indices for this location, it is slightly different than both Indiana and Alaska. Although the multiplier for work RVUs is slightly more than Indiana, it is less than Alaska, while the practice expense multiplier is greater than both Indiana and Alaska. California is commonly considered a very favorable state with regard to professional liability insurance, and therefore the multiplier, or GPCI, for this particular issue is less than the two previously mentioned states. In total, the proposed value of 19.00 RVUs becomes 20.91 in San Francisco. And once again, when multiplied through by the conversion factor, this naturally provides a total reimbursement that is somewhat in the middle between Indiana and Alaska. Finally, let's look at the East Coast. Florida is commonly considered an unfavorable state with regard to professional liability insurance. So whereas the total amount of work RVUs multiplied through in the GPCI for Alaska was the greatest, and the practice expense for San Francisco was the greatest, here in Miami, the multiplier, or geographic practice cost index for professional liability insurance, is the greatest. When one multiplies all of these values through, one can see that the proposed value of 19.00 becomes 22.84, multiplied by the conversion factor, and this provides an overall reimbursement of $816.64, in close proximity to the Alaska reimbursement, but slightly less. It is not difficult to recognize that there are significant efforts to reduce overall expense of healthcare in the United States. Efforts are ongoing to reduce the reimbursement to all members of the healthcare community, including hospitals and physicians. However, when one reviews recent literature, it's clear that there are specific aims at physician reimbursement. Specifically, within the Affordable Care Act, the Independent Payment Advisory Board, or IPAB, was developed. It has yet to be instituted, but this entity, which is a 15-member group, is aimed at identifying significant reimbursement issues for physicians and is able to make unilateral decisions to reduce overall physician reimbursement. The RUC is also making efforts to reduce the overall reimbursement by identifying misvalued codes. It has been successful in identifying over 700 codes that have led to a significant decrease in the RVUs for these specific codes. Approximately 28% of the codes that were identified as misvalued remained unchanged, while a significant portion were even deleted or remained under review. Only a very small portion of codes that were initially identified as misvalued actually saw an increase in the RVU valuation. I have now completed the summary of the CPT editorial panel application process and the method by which CPT codes receive an RVU determination. Although the process for each may seem straightforward initially, as one can see, it is exceptionally complex. In fact, each member of our team has dedicated more than 3 years to learning the terminology and methods of each committee. Our goal is to represent you, the member of SAGES, in this regulatory field. If you have concerns regarding SAGES message or representation in these areas, please contact Shelley Ginsberg in the SAGES office. Thank you for your time and interest.